October Next Gen GP webinar. Thanks everyone for joining. My name's Nadija Coralagay. I'm a portfolio GP in Colchester. I led on the Essex Next Gen GP programme, and I'm standing in today for Will, who's on parental leave. So congratulations, Will. But I'm in good company, really good company, because I'm joined today by the amazing Dr Farzana Hussain, who is, amongst other things, a GP partner, clinical director for Newham Central 1 PCN, and co-chair of the PCN networks at NHS Confederation. And of course, she's also very well known for being GP of the Year 2020. So it's going to be another really good one. Right. So Farzana, thank you so much for joining us. It's so lovely to have you here.
Thank you so much for having me. Thank you to everyone for spending some of it. I'm seeing some great familiar faces, Camille and our very own Lucy from Newham, and Sonali, and Alia, who's already kindly said she's going to be tweeting for us. So thank you for keeping me company.
I've mentioned quite a few roles that you have, but we were all wondering who's the real Farzana Hussain? Who's behind it all?
It's a good question, isn't it? So I think the real Farzana is I'm a GP partner, and I've been a GP partner for 19 years, and all my other roles come from wanting to improve my practice and my care for my patients. And I'm a mum, although Nish and I were just talking earlier about mine are not babies anymore. They're 17 and about to be 18, but I love reliving the memories through Nish's tweets. But I very much love being a mum, and I think that has actually enhanced some of my GP work, but it's not easy to juggle it. So I really feel for all the fantastic mums and dads out there, and Will, who are juggling those things, because it's not an easy thing to do. But that is me. Little bit bonkers, that's me, and that's the feedback I've had from some of my confed board. You're lovable, a little bit bonkers, but we love you anyway. Feedback.
Okay, well, I mean, it's nice to hear, when we speak to our role models, it's really nice to hear that authenticity, that they are the same person that they are at home, and I guess you've maintained that authenticity throughout. But just thinking about where you are now in your career, what do you think the kind of pivotal moments have been that have led you here today?
I think there's probably three stand out. So one is when I became a doctor, because in the first year of medical school, and I trained in the University of Wales in Cardiff, but in the first year of medical school, sadly, I lost my mum, and she died in my first term. So when I became a doctor, some of her last words to me was, I want you to go back, because she was in hospital and she didn't look well. And I said, shall I stay with you on the Sunday? And she said, no, of course not. I want you to go back to medical school. I want you to be a doctor. She wasn't a doctor. And she died 5 days later on the Friday. So when I became a doctor, I was sort of very proud to be doing it for her as well as for myself. So I think that really stood out. And I think having had that experience of a parent who had heart failure has probably stayed with me to how I look after patients. And I think many of us have that if we've had a personal connection in health as a user, as a patient. I think the second experience, Nadija, was when we were a two-partner practice. I'm a single-handed GP now with fantastic, fabulous salary GP support. I mean, not on my own, but we were a two-partner practice, and we set up the project surgery back in 2003, and we were a greenfield site, meaning there were no patients. We were born out of what our local community wanted, and there was some urban regeneration funding, and they asked them, do you want a school? What do you want? They all said, we want a doctor's surgery. So we were very much born out of what our local community wanted. And my partner, Peter Jones, had also been my trainer and my program director. And he sadly, we lost him to suicide 7 years ago. And I thought, how am I going to keep this practice going? How am I going to do it without him? He was always my guiding light. And how am I going to do that with a 9 and a 10-year-old? So I think that's something that I'm really proud of, and credit to my team. I couldn't have done it on my own, that we went through that, and we went through that together. And I think that is probably a very defining moment for me, because I had to use all my strength and think about, did I want to? And I wanted to. I didn't want my patients to be dispersed, because we would have been closed down otherwise. I didn't want that. Um, and I think the last year, being delighted to have my first national role and doing something that I so believe in, being having the honour to be representing primary care networks nationally, because I so believe in them. I so believe that it's going to improve patient care with a joined up way, and help our workforce, which are, who are under stress at the moment. So I think those three, I would say.
Wow. I mean, what a journey. That's amazing. And you mentioned you've been a GP for 19 years now. I imagine, I mean, of course, you've seen some massive changes. How does general practice feel different to now to when you started? And actually, how would you like it to feel in, say, 10 years' time?
It's a really good question. So when I qualified as a GP in 2001, that was really just the birth of the salaried post. A friend of mine went traveling for a year and a half, and I became a partner straight away. And when she came back, there were barely any partnerships. And so before, back in my day, that most people became partners. And I think that that has had a lot of positives. I think it's also had a lot of negatives. I think that partnership hasn't had a good profile and a good reputation. And, I'm a GP trainer, and I think many of our younger GPs feel that they don't have the skills for it and feel de-skilled. And actually, none of us have the skills for it. GPs are clever people. It's an experiential learning. So I think that that's one of my regrets over the years, that GP partnership has had such a poor reputation, and that whatever we have done as partners, we haven't managed to attract a lot of our salaried GPs to become partners. I don't think we've ever been more regulated. So when I started, there was no CQC, and I think that there is definitely a purpose for CQC. We want to give people assurance, and I'm a CQC specialist advisor myself, but I do think that that has put, perhaps the method and the way it's been done has put an added amount of pressure on an already stressed workforce, because we haven't got enough GPs in the country. So looking forward to the next 10 years, I'd like to see some of the innovation that's happened with COVID. COVID has been a tragic thing, and obviously in Newham we've had the highest COVID death rates in the country. But one of the silver linings is how we've been allowed to just get on with it without it. And my gosh, hasn't general practice shown as part of the NHS that we have completely transformed in a matter of days, to go digital, to go telephone, to make those transformations, which actually no other part of the system, the hospitals, no one's been able to transform in that way. So I'd love to see more of that, because when we as GPs and primary care are left to it, we deliver. So I'd like to see that again, and let's see a bit more joy back in, a bit more joy that I saw back in 2001, because I think we're a bit tired and over-regulated at the moment.
Mm-hmm. So in this environment now that you describe, I mean, you mentioned when we were chatting before, you mentioned this is your third, and it could have been your fourth, but it ended up being your third kind of webinar or meeting like this of the day. How do you find the energy? Because whenever he heard you speak, you're so energized. What's your motivation? How do you keep going?
So either I've been born with far too much serotonin in my brain, it could be that, but also I really enjoy what I do. So I have to say, maybe I'm a bit odd, but burnout is something that's not a word in my vocabulary. So I might do some lab links tonight at 10 o'clock because I've been on 3 webinars, but actually I don't find that too difficult, because then I know I'll be doing something else tomorrow that's meaningful. So the two things for me are having a lot of autonomy over my work, which GP partners can have, and many salaried do have as well, but having a lot of autonomy helps me. having really good support. I have got a fantastic team. I couldn't do this without my 3 wonderful salaried GPs that support me. But really finding it meaningful. So I got interested in primary care networks because I about 3 years ago I got interested in NAPC, the National Association of Primary Care, their primary care home model, which was the precursor of the primary care network. And I just loved the joined up aspect of it. Now, many of us will know, like I talk about my patient that I had, and she's got osteoarthritis of the hip, Khadija, and I think that'll be quite easy. I work in a densely populated area. The hospital is under a mile away, and I wrote a letter to the physio, and she got there with a painful hip, and they said, we have got no record of your referral. She came trundling back with her painful hip. Another contact for me. I sent her again, and this time we've cancelled your appointment. And by the time she went, by the third time, with 2 unnecessary contacts with the GP who was like, I've got more pain than you now because actually I don't know what to do for you. I was like, what are we doing wrong as a system? What can I do in my consulting room that's going to help? And I think the primary care network allows some of that. Already we're seeing the physio roles coming into primary care. So I think that's my motivation. I can see results, and I like seeing that, and that gives me a bit more energy to keep going.
Thanks. I saw on Twitter recently that you retweeted the great Simon Sinek saying, leadership is not a rank or position to be attained. Leadership is a service to be given. I thought that was a really interesting, powerful statement to pick up. What does it mean to you? Because you've spoken so much about seeing changes, but as a leader, what does that mean, and how do we achieve it?
Yeah, it's interesting because that really spoke out to me. So I retweeted it. I guess it links to what I was saying earlier. I've never seen myself as a leader. I've seen myself as somebody who wants to achieve 2 things, and that's improved care for my patients, things that at the moment I can't deliver, even if I'm good at my nice guidelines and everything else. But I can't deliver what's happening with the physios and the bits I don't have influence. And so that's one goal. And the second goal is to try and improve things for our primary care workforce, from our nurses to our admin staff to our salary GP partners who, are all under it. And so I think of it as a service. And I go back to 7 years ago when I had no national leadership titles, and I wasn't on a GP federation, and I wasn't on LMC and all the various titles that I've had since. But actually, that was probably for me personally the biggest demonstration of leadership that I had. I had 5,000 patients, and I wanted to make sure that I still looked after them because we were born out of them. And if I didn't do that, the practice would have closed, and they would have gone to perfectly good neighbouring GP practices, but they wouldn't have been my patients anymore. So that's, I think, for me, the biggest personal example of leadership, not having I'm on NHS Confederation title. It's lovely to have the title, but for me, it's about what I can achieve with that.
That's really interesting. Do you feel there's something special about you being at the surgery from its inception, from its demands, and seeing it right through?
Funny you mention, I call it my baby because my son was born in 2002, my practice was born in 2003, and my daughter was born at the end of 2003. So I say to my daughter, you're actually my 3rd child, and my 2nd child. And I know a lot of GPs feel that, a lot of GP partners, particularly where I am in Newham, we've got a third of our GPs over 55, and absolutely passionate about their patients and their practice. And I think it's helped me with my other roles. One thing I don't want to do is become so strategic and corporate that I forget what it is I'm trying to deliver. So I think if I was ever seen as a professional leader, I'm doing something wrong.
Right, thanks. I just want to throw out a last question alert to the audience now, because I've got one more, and then I'm going to open it out to the floor, so I'm not hogging you, Farzana. So I just looking back over kind of the last few years, well, 19 years, I suppose, and thinking about everything you've done, and perhaps looking forward and thinking about what is yet to still be done, what would you like your legacy to be, kind of professionally, personally, however you want to answer that?
So personally, I'd love my two children to go into medicine. I so like it. I so love it. I think it's such a worthwhile thing. And I think, what can you say to teens? But I think with COVID, my son, who's in upper sixth at the moment, has actually seen some of the benefits of being in the medical profession as opposed to being a social influencer, which is what he wanted to do before. He wanted to comment on his FIFA games and be a social influencer, but at least he's had a slight change of heart. I'd love to have a more positive narrative about general practice and primary care, because there are a lot of people who are overworked, and yes, it's busy, but actually I work in an area where we've got the highest furlough rate of employees in London. Lots of people are going to lose their jobs. I am fortunate that I don't need to think twice about whether I'll put food on the table for my kids or not. I'm fortunate to be able to turn work away, and I find it really meaningful. So I'd love one of the legacies to be a bit more positive about general practice and primary care in general. And I'd really like to see my dream of the primary care networks be achieved in the primary care home style. I think that might take a few years. I think it's a big transformation. We're on a journey, but I'd love to see that I didn't have any more patients who were turned back 3 times just to go see a physio. And I think primary care networks really have the potential to achieve joined up care, and to be able to try and do that across the country is why I'm so excited about my confederation role, because we can level up care whether you live in Yorkshire or whether you live in tier 3 Manchester or whether you live in Dorset, and I don't think we have that at the moment. So I'd love to leave that legacy that our patients are getting the joined up care that they think they already have. They believe the NHS is one homogenous organisation. So I think those would be my two memorial things.
Oh, that's so interesting. Every answer just throws out more questions in my head for you, but I'm hogging you. So I need to share the love here. So there's a great question from Camille. So Camille, would you like to ask it? Do you want to turn on your video and unmute yourself?
Thank you so much for that inspiring talk and comparing as well, Nadija. My question is related to the positivity in general practice. I think positivity is related to people knowing what's unique about GPs, what GPs can provide. How can we make sure that the public and other professions, even our colleagues, even ourselves, because I sometimes see it in GPs themselves, realize what an intellectual and socially incredible profession it is? And you sometimes only see it in GPs who are more experienced, having that amazing skill. How can we make sure more people know about that?
So I think, Camille, that's a really good question. My answer to that is it's a simple answer. It's hard to do. So actually get people in a room. So when we say how can we engage patients, why are they not in the room with us? So in primary care networks, for example, we should have patients there, and some do. In Milton Keynes, they've got some great stuff going on. But at the moment, we're seeing a huge miscommunication, if you like, aren't we, where people think that general practice is closed or has been closed, whereas GPs are saying we've never been busier, we've just gone digital. So there's a massive communication gap, and I think it's about getting together, even if it's in a virtual room with COVID. And we're all different people, so I don't really know exactly what the physio does at the hospital, and they probably don't know exactly what I do. I think it's about joined up getting to know each other and those relationships. And another reason I'm always raving about the primary care network is because there has been some evidence with the primary care home that if you're looking after a population of about 30 to 50,000, it's about 100 staff members, and like people can, you might not know everybody's name, but 100 staff members is a figure that you would be able to have some of those relationships with. And listening to each other. So my lunchtime talk was about staff well-being, and are we sure? Like, do I know what my salaried GP's issues might be? So one of my salaried GPs, well, they're all young mums, but she needs to pick up her little one at 1:45. She absolutely has to do that. Otherwise, nursery, you get fined and you're bad mum and, all of those things. And she was realizing that she could see the patients, but she couldn't finish all her lab links and her paperwork. So I said, well, do you want to go early? And this was pre-COVID. I said, do you want to do that bit remotely? When you've got a cup of tea and you pick little one up. Absolutely changed her life. She was like, thank you. And I said, but you're getting the work done. I don't really mind whether you do it on Jupiter or whether you do it here. But so I think really making some quick, wins to help that positivity. People often get negative because they're not heard or they're overworked. There's something wrong with humans if we're feeling negative. There's a reason behind that, isn't there? I can see this lovely lady called Mary Harrington, and the little cutie has stolen my heart. And if we don't do it right, nobody wins, because somebody as talented as Mary will leave the profession. So I don't think anybody wins. And then we say, oh, we've got lots of negativity. But times are changing. I used to be a little bit embarrassed taking my kids to meetings. They went everywhere with me. They went to meetings. But it's lovely to see now, actually, 15 years later, that there are baby-friendly events. That would never have happened 50 years. I was like, I'm really sorry about my little one. They'll try not to make noise. I'll give them a biscuit. And it's really nice to see that positive change, that now people can be proud to take their kiddies. I was the only one in the whole of the borough that did that. So I think the long rambling answer is, let's try and understand why people are negative and see if we can change that. Sometimes it's the smallest thing, and sometimes it's the largest things. It could be that for some people, general practice just isn't it. That's fine also.
That's great. Thanks, Camille. Next, we've got another really good question from Sonali. Do you want to turn your yourself on and turn your video on and unmute yourself?
Sorry, hi Nadija. Hi Farzana. Sorry, I think my video for some reason has been stopped by the host, so I'm not sure.
Oh, Sonali, you're too beautiful. You have to stop the video. Stop the video. I can't hear you.
Still at work, so yeah, no, I can't seem to start the video, so I'm not sure what's happened there. But don't worry, I'll get my question hopefully across. So great to see you, Farzana, and really well chaired, Nadija. So I think, Farzana, just really interesting insight about partners and salaried, what you said there. And I just wanted to get your thoughts on kind of how do we bridge the gap, and start to really change the culture in the individual GP practices. There's still some people who are in the hierarchical mode, and there are some there's new leaders who are really kind of knocking in on the door, wanting to burst through, coming up with ideas, but they're not being given that space. So there's become a bit of kind of them and us culture, isn't it? And I think people have had a tough time on either side. So how do we really start to make that difference? Because I think what's going to impact the most on retention, workload, yes, but it's going to be that culture.
Yeah, that's a really good question, isn't it, Sonali? And I think that actually we've never been in a more positive place, because certainly with clinical directors and leadership roles, next gen GP, for example, we're seeing a lot more salaried GP leaders, more than I've ever seen before, actually. But I think that when we talk about culture, we need to remember that there isn't a homogenous culture. And one of the things with primary care is that we are not a homogenous organization. We are just in Newham 46 independent businesses. General practice is an independent contractor model. So one practice might be absolutely great and going and saying, yes, salaried GPs, you do this and you be the QI lead. And another practice might be like, well, actually, I'm fine, thanks. So I think it's a little bit about for our salaried GPs to also think about what they want. So I've had one of my salaried GPs who's so great. I just love her to be a partner. She doesn't want to do that. She wants to concentrate on raising her family at the moment, and she'll think later. So that's not a question of exploitation or hierarchy. That's a question of what she sees is important in her life at the moment. So I think I'm not really answering your question because I don't think there is a homogenous culture. I think there are different cultures. And I think it goes back to listening to what the individual wants. Not so much in Newham, but next door in Tower Hamlets, we've had a whole host of partners who have decided not to be partners anymore and become salaried because they actually felt it wasn't worth the responsibility, the risk, and the pay, the few extra pennies of pay. So I think it's a good question. I think the opportunities are much better. And I think some of that hierarchy is going compared to, say, about 10 years ago, when it was very much, the salaried are the operational workforce and the partners are like, I'll come in for a bit and not. My experience is a bit different because I've always worked in a small practice. So if you're in a small practice, there's only one or two of you. So you have to get your backside in the practice or else nobody would run it. But I think there has been, certainly in larger practices, sometimes the feeling that it's actually the salaried GPs that, are taking on the brunt of the work. But I'm loving seeing so many salaried GPs as clinical directors, as clinical leads, lots of CCG leads. I think more to be done. Talk to each other, see what we want, and we won't manage without our salaried workforce, of course, because there's more salaried GPs than partners at present. And I didn't even mention the locums, because bless them, the locums have had a really hard time with COVID, and they're still very much needed in a different way, but I won't open up that can of worms right now. But you're very valued if you're a locum. We do need you.
I'm a locum. Thank you. I thought that was a really interesting question from Sonali. So would you have advice for someone who found themselves, because each, like you said, you've got these individual businesses and they run certain ways. So if someone finds themselves in a position where actually they're not getting doors open to them and they're not getting opportunities and they're salaried in somewhere where perhaps in their practice and in the practices they can see and access, it feels that way.
What? I would say don't be afraid to ask. So when I did some of my quality improvement training, there was lots of salaried GPs who were just bursting with ideas and then saying, I can't make this change at my practice because the partner doesn't want to know. And I said, but have you asked them? Because it could also be that your partners are actually really scared and over-regulated and really busy and haven't thought about it. And I think it is a bit of both. Hierarchy can only be present if both parties feel that it's present. So I would like to think, and we need to get feedback from my salaried GPs, I might have got this wrong, but although I'm the partner and they're salaried, I'd like to think we didn't have a hierarchy, because actually there's 3 of them and 1 of me. So I could never manage without them. And they've got the power. If they basically down tools and said, we're not going to work anymore for God, I'd be up the gum tree. So they have the power, although I'm the partner. So I would say don't be afraid to ask, because it could be that your partner just doesn't get it and is a blocker, or it could be that they just don't know and they can't think of how to do it differently and how to do it better, because partners get frightened too. And partners, speaking as a partner, we've got our CQC to get through, and we've got to make sure that we have a budget where we can still pay everybody, we pay cuts, so they've got their own issues going on. It could just be that they might want to do something, they just don't know how to do it differently. And this is where we need our salaried GPs who can say, I could help you with this, or I could be your new partner, or I could do some QI for you. So I'd say have those conversations. What's the worst that can happen? They can say no, and then you'll move on to another practice. But they might just say, Thank God you said that, because that was all on my mind and I didn't know how to do it. And that's been my experience. I mean, my salaried GPs, as I say, one of them, I'd love her to be a partner. It's not her time at the moment, but that's not to say we don't discuss things and she doesn't help and support me. She's my absolute backbone. That you will know, Lucy, Dr. Iram Ali is my absolute backbone. I'd be dead without her, to be truthful.
Well, it's really nice to hear that you value your team so much. That's really good to hear. We've got another question from Miraj. Miraj, are you about? Could you unmute yourself?
Hello.
Thanks.
Hi, Farzana. Thank you so much for coming on tonight, speaking to us. Obviously, you're a great inspiration for so many GPs, just like myself. I just wanted to ask, I know you mentioned about PCNs, but there's so much negativity currently within some GP practices, and just thinking about how to build this onto PCNs, because sometimes when I speak to GP colleagues about PCNs, because there's so much negativity, they would probably end up saying that actually this is just another political stunt with the PCNs, just because they can't get enough GPs, they want other health professionals to come and replace us. I'm just wondering what sort of advice you'd give to younger GPs to try and help us change that attitude.
Sure. So I think that's such a great question. We're seeing this. Miraj, I always start with, you can only change yourself. You can't change anybody else. Primary care networks are it's a bit like Marmite. You either love it or you hate it. We do know that for primary care networks, particularly for GP partners like myself, it's going to be a massive mindset change. Why? Because I run my own business. I am not just a GP, I'm an employer. It's like running a shop. I run my own business. I pay my own bills. I pay my own staff. I need to see what's going out, what's coming in. And then suddenly, if you put me in a network with 6 other practices, as my network is, we might have to share some of our sweeties. And we're not really geared up to sharing, because the model so far has been very much about, this is your practice and we're 7 individual practices. So I don't think we should underestimate the mindset change that we're expecting from partners. Might not matter too much to the salary GPs, because they can work across the network, or their salary might not change. But for many practices, they're very worried about, will their business still thrive? As a clinical director, what I do is I try to think about, as I said before to Nidja, can I improve care for patients? Can I also make things better for the workforce? We know that we don't have enough GP. So any GP that says to me, the 12 ARSS roles are going to take my job away, they haven't been listening to the 5,000, or actually, are we 5,000 short? Are we actually 10,000 short? Because nobody works whole-time equivalent. Are we actually 20,000 short? So there's no risk that a GP's job is ever going to go away because we've got some physios. We haven't got enough. But my job as a clinical director of a PCN is to demonstrate why my GPs would give up 2 hours a month to come to a meeting, why they would spend that time, what will they get in their practice. That's a challenge to myself. So a small thing we did was one of the QOF domains. We did some quality improvement across the network, where we now do as a clinical thing, the high risk drugs like methotrexate, warfarin. We did a protocol across the 7 practices, so we were all doing safe prescribing and following it the same way. So that's a good bit of clinical practice. It helped the ones that might not have been able to think about it, and it's a CQC tick there. So we managed to get 3 things, and then the practice is like, oh, this is great. So it's about making the network meaningful for practices as well as patients and all the other staff. But I do agree with them, and I think it's a journey. We are expecting a very different way of working for autonomous independent contractors.
Thank you. Thanks. That's great. Again, it's good to hear you're always talking about teams and people kind of pulling together for that kind of shared purpose and taking that forward. We've got loads of questions now. Keep them coming. They're so good. I don't think anyone's giving you an easy time though. So our next question is from May, and then after that it will be Nazir. So May, if you want to unmute yourself, if you can.
Yeah. Hello, everyone. Hello, Farzana. Lovely to see you and hear from you. So my question is, what was your most challenging project, and how did you manage it, and what did you learn from it?
Yeah, what a good.
And yeah,
I think my most challenging project was keeping a practice going in November 2013, when we were just hitting a flu epidemic, when my partner passed away suddenly. My salaried GP was on maternity leave, and I, Muggins, was the only doctor in the practice, looking after 5,000 patients, with a 9 and 10-year-old who I chose to pick up from the school gate every single day. That's the mum I chose to be. And I thought, how am I going to do this? And I think my proudest moment is when I got my little team together and I had a chat with them about a week after the death. And I said, I think you all need to find another job. You've all got mortgages to pay. And I don't know if they'll keep it going. And they said, we will never leave you. That's what they said. And because they said that, I thought, if they have that much trust in me, I will keep it going.
Gosh, that's so powerful.
Amazing team.
Yeah. And I don't know, there's some, did you ask them why?
I asked them why, and they said, we think you can do this. And I said, well, actually, he was our senior partner. And they said, we don't think you know how much you've been doing, and we're right here to support you, and we will not look for other jobs. And I thought, these people have this much faith in me. They think I can do it. And that's, I think, one of the the power of positivity. We forget that when someone is saying to you, I believe in you that much, even if you have a struggle, you think, oh, if they believe it, maybe I can do it. And we did, and it was absolutely thanks to them. And I think that's been my biggest personal success, definitely, to have people believe in me that much. And I didn't need to miss a school run. We did it. We got some locums in the afternoon. I logged on in the evening, but we did it. And I think you can do anything you want to if you believe in yourself and you've got people around you who have that shared purpose.
How do you curate that environment? How do you sorry, May, were you asking something as well? You're on mute. So sorry, I'm stealing the tail end of your question. Sorry. But you're still on mute at the moment, May.
yeah, okay. No, don't worry. It's a follow-on question. It was about how do you look after yourself in such difficult times? At
that time, May, I'm not good at exercise, but at that time I did lose some weight, not because I wanted to, because I was so busy. I think we all need things to ground us. I think my faith helps. I knew that whatever happened, I wasn't on my own, that there was a creator, and that helped me personally. I think having kids around helped, although they were extra work. Any parent in here will know that no matter how bad a day is, when you've got your 9-year-old saying to you, and actually, Mum, I don't really like what you made there. Can you make this instead? It's a really grounding thing, isn't it? When I got my ranking photo, all my 17-year-old could say, yeah, that's great, Mum, but can I go out shopping with my friend at Westfield? Can I stay out half an hour later? And it's a very grounding thing to get put back in your place. And I suppose the third thing, it was really meaningful because I knew that my 5,000 patients wouldn't be with me anymore. I knew that they would be all over the place. And I really wanted to keep them together. I wanted to be their shepherdess, if you like. So there's those three things.
Thank you. Amazing. Like it's again, I keep on saying this, but it's amazing just to hear you speak. And everyone, remember, keep on tweeting. It's the hashtag is, well, hashtag NextGGP. So do get it out there. And also, I haven't been reminding people to introduce themselves, please, when they ask a question. So thanks, May. That's a great question. Next, we've got Nazir. So if you want to show us yourself on the video and unmute yourself if you're about, Nazir.
Don't be shy, Vivian.
Well, what we could do maybe is move to James. I think he might have a few questions for you, actually.
James?
Thank you very much. Hi, I'm James Waldron. I'm a GP portfolio and salaried in Nottinghamshire and helping run the East Midlands programme, which is just getting up and running, and done Next Gen for the last couple of years. Really lovely to meet you. So I was picked up on what you said earlier about tailoring general practice for the individual, and I think that something I reflect is it somewhat saved my career being able to do a mix of different things with clinical and non-clinical work, and it's stimulating and interesting. But I think one of the big things is about how we actually deliver the practice, and you've been mentioning about sort of remote consultations and the like. And I think that's really impacted on patient care, but also on us as individuals, as clinicians. It changes a core part of the human part and about the thing that we experience differently as individuals. And I was wondering what sort of effect you think that it might have had on clinicians, on people around you, perhaps on yourself, as to I suppose the wellness that you feel in delivering care, and about how, and I suppose the second part would be about how do we roll with this and continue in the future to both deliver great care for our patients, but also remember to care for ourselves throughout it.
Yeah.
So
what a great question, James. And I think I've felt it. So I'm an extrovert, but I'm actually, if I look at this, I'm an extreme extrovert. So
Me too.
actually, and you too, and so I get energy from just being in a room with people. I don't need to talk to them, but I just want to be there. So when we moved to total online triage in March, we will still see patients, but it will be after an online, and if they can't do online, it's a telephone, then we'll go to video, and then it will be face to face. So I've been doing a lot of work in a room by myself, and I found that really isolating. But one of the things that I always go back to is ultimately my job isn't here for me to feel better. My job is here for my patients to feel better. It's not occupational therapy for me. And the reason we went to total online triage is because I could see immediately as lockdown hit that many of our patients thought that general practice was, but they would only call us with COVID things, even though they were supposed to go to 111. They weren't sure. And by giving the online access, we had 24/7 access. So it wasn't just 8 till 30, which we were giving before. My patients anyone who can use online, which is the majority of our patients, can put in online requests anytime. You're 2 in the morning, 3 in the morning. They don't, but they can do. But in terms of my well-being, I have felt very isolated. I go into the practice just to see people. They say, "Why are you here today?" Because I missed you. I said, "I've got a bit of paperwork to do, which I couldn't do at home, but I go in to see them." And then I worry, we need to be social distancing and, not doing that hug. I think, not hugging people for someone like me and a lot of us is very unnatural, and don't come too close. But we haven't been that good as a practice, but a friend of mine in Merton in Southwest London, if anybody's from Southwest London, at Wideway Medical Practice, they are mindfully putting in things like virtual coffee breaks. So the whole team, so even the doctors, no matter how busy they are, they will down tools for that 10 minutes every day. They will do a virtual coffee break. So some sort of virtual connection, because I think many GPs are people, that's why they like going into it. And I think you raise a really important point about our own well-being. So while my job isn't to make myself feel better, and I would never go back on the online model because it's provided more access, I think it's more efficient time-wise, and we're going into a surge. I need to make sure that Newham's already had high COVID death rates. I would feel criminal if a patient was coming into my practice to see me face to face and got COVID because of that, if I didn't have to see them. But our own well-being, remains a concern about that isolation, and also how we've had to work very differently. So human beings, like any mammal, can only manage so much change, and we have expected like change after change after change for our GPs, without much training or anything. Like go online, do the telephone, without a lot of training and support. So I know NHS England are providing some great coaching opportunities if anybody wants to take that up, but it's I think me as a partner, it's my responsibility to ask people, how are you doing? How are things? Are you actually worried about your kids at school picking up COVID? Are you worried about your mum who's got diabetes? Because we've got a lot of our own personal worries. I mean, I worked with the 5th GP in the country to die, was one of my Federation board directors. I knew him quite well. And I think all of that has had an effect. I'm much more I keep mothering other GPs saying, make sure you've got your PPE on, and irritate them. But, because I've had that experience of someone I knew who died very suddenly, it has made me a little bit more anxious about my colleagues. Do you really need to do that home visit? Do you need to do that? Which perhaps I wouldn't have said before.
That's interesting. You've got the doctor equivalent of make sure you got your coat on.
Absolutely. And I think it's the mummy. I mean, I need to basically look after Nisha's baby for a bit, because I've got this mummy thing going on, and mine are on. Nisha's saying fine, and I'm like, get your coat on, put your PP. Do you really need to go for that visit?
Yeah. We'll just send you all the baby checks and keep you happy. So we've got Nazir back in the room, I think. I'm hoping. So Nazir, if you could turn your video on and unmute yourself, that would be fab. Thanks.
I think you have blocked my own video.
Here you are, Nazir.
Oh, yeah. Hi, yeah. You lost me for a few minutes. My computer just turned off. So I'm still a GP registrar, finishing my training in January. But what I struggle with is the fact that with these loads of patients that you have to see, which is not unique to myself, of course, how do you navigate quality improvement initiatives and getting them to scale through when the focus and the energy being put in by some of the big shots in the practice that call the shots are not necessarily in line with your thoughts and aspirations?
So did I understand your question right, Nazir, that how do you embed something like quality improvement if the decision makers in the practice are not willing to go with it? Was that your question?
Yes, and that's one. And then still channel energy despite seeing this loads of patients with this so much workload, and still focus energy on the on quality improvement at the same time.
Yeah. So I'm a bit of a quality improvement fan, as many of you will know. But I think it's that old saying of, you need to put something in to get something out. So quality improvement does require some time initially, whatever you're embedding, but then it will pay off. So, a quick example would be, for us, for example, we found that all our GPs, so there's 4 of us, and we were all recording feverish children differently. Someone like me was putting looks well because I know the patient, and not much more. I mean, my record keeping could have been a bit better. One of my salaried GPs, just great, just come off BTS, had the pulse, had the blood pressure, had you name it, she had it. So we wanted to do a quality improvement activity to standardize that care, and it was actually one of my salaried GPs who made up a template for us. I was fortunate that everybody wanted to do it. The question of what to do if they're not all on board, or if your partner's not on board, 2 things. You can either, so back to partners, we are often deemed as the most influential person in the practice. We may not be. I am one of 10 people. So if my 9 say, Farzana, we're doing this, you're not doing that, there's actually not much I can do because there's strength in numbers. So you might want to do this first follower approach that they talk about in leadership, Nazir, where it might not be your partners, but it might be that your nurse and your admin and another sort of the salary GP is really interested. And if you get a little cohort of you together and you can demonstrate something, your partner will come on board. There will be a few what they call the laggards, the small percentage will be like, no, I'm not moving. You're not going to change anything in my practice. There is that, but they're generally the minority. So I would say that if you're passionate enough about it, I would talk to people who are a bit not sure. Don't talk to people who are an absolute no, because that's going to be harder for your energy. There might be a lot of people who might say, might be quite a good idea. And if you can demonstrate something small, so my online, for example, I thought my receptionists are going to get their heads kicked in, because every time you make a change, none of us like change. And it's about week 6, and I've done a few quality improvements. About week 6, you need to go in with your hard hat on, because your team will swear blind that they never agreed to anything you said because they're under pressure, and you basically go into the bathroom and cry, and then you buy them all a chocolate bar, and by week 10 everybody's fine. Like, oh, did we do it a different way? So change is hard. I said to my reception team, what's your biggest problem on the phone every morning? And they said, like most places, people keep shouting at me saying, you haven't got enough appointments, and I've been waiting on the phone for half an hour. And I said, do you want to do something that will take 90% of that away? And they said, yes. And I said, do you want to then be in pain for about 4 or 5 weeks while we change it? And they said, yes. And that's how we did it. So it's about giving people and showing people that there's going to be a benefit for them. And there's going to be a few blockers, but they're always, but there may not be. The fatigue about seeing patients. So Nazir, how I manage that, and I think what James is saying, if I've understood you correctly, I like doing different things. So when I first qualified, I did 7 sessions as a GP when I was a new GP. Then I went down when I had kids, became an appraiser, and now I do so many different things that I'm all, they say a change is as good as the rest. So, I love seeing my patients because I'm meeting out most of the time. So, and I think we all have different thresholds. So, you might have a skill in something that's not patient facing, or it could be that for you 2 sessions is enough, or it could be that you love 7 sessions. So I think there is something about, certainly for me, like understanding myself and what I like to do, and that helps me from that fatigue. I know when I've done too much, because I start complaining about them. She said this and she came back with her back pain, and that's a sign to me that actually, no, I need a break, because now I'm blaming her. Sometimes that break is just tweeting. I'm a bit of a Twitter addict, and I laugh about it, but I actually find it quite therapeutic. If I've just had a patient shouting at me, my housekeeping is, let me just go on Twitter for a minute and then I'll go back, because sometimes just changing. So whatever works for your mental well-being, but I think it is something to, the fact that you've been thinking about it as a registrar shows how very forward thinking you are. I just think you're going to be fine.
Thanks, Nazir. That was a really good question.
Thank you very much. Thank you.
So insightful, because I think the problem happens, and in my GP appraiser role, the problem happens when we don't have insight into that, when we don't think that, we think it's fine, I'm going to do 21 sessions a week, I'm going to do 3 sessions a night, and then I hate all the patients, and then it's the question of, do you think you might be a bit overtired? So at least you've got that self-insight.
Great. So next we'll move on, because we're nearly out of time, I guess. So next we've got a question from Julia. Julia, if you could introduce yourself. And
yes, hi everyone. My name's Julia Hempenstall. I'm a GP, and I think I guess I put myself as a portfolio GP to exactly what Farzana is just saying, to keep yourself interested and try lots of stuff and keep yourself energized. It is so lovely to hear everything you've said this evening. So much experience and so much importance for next gen GP as well, because part of it is bringing on people to understand, listening to your amazing stories. And I saw in the chat someone was tearing up, and I think I did too, to hear so much of your life experience, because that's where we build resilience, isn't it, by realizing we can get through it. But one of the questions I wanted to ask you was a little bit about, I think our practices are quite similar, small, and obviously you're leading this single-handedly essentially as well, and I choose a small practice because I love the continuity of care. I absolutely love it, and today I've actually done a remote session from home and speaking to patients, and it's been completely liberating to be able to do that. I love the relationship, but I'm worried about the future, and I wondered how you feel small practices are going to manage as we move into this more larger workflow type work between PCNs, and whether you had any expertise or advice.
Such a great question, and thank you for your compliments, Julie. I think you're right. In terms of resilience, you never know what you can achieve unless you're faced with it. You'd asked me 8 years ago, can you run a practice when your partner's just in, he was my best friend who's just dropped dead. Of course not. But when we're faced with something, it's amazing how resilient, we are as human beings. So one of my very selfish needs before I started finding out about the primary care home, when there were these talks about these things called primary care network that might be coming in 4 or 5 years time, I thought, oh, I wonder what this is all about. And I started looking because I knew that I'm certainly the smallest list size in our 7 practices. And I thought, oh, what's all this? And as Miraj said it, I was a bit suspicious. I was like, oh, is this a takeover? Is someone going to try and take my practice? And I thought, after everything I've done in my practice, there's no way anyone's going to take my practice. And actually, I've completely changed. I see the PCN as actually the support for a small practice like mine. I'm very concerned about this winter and the second surge because just of the number of staff isolation. So when March came, 50% of my staff were isolating. And I know that happened in big practices as well. And that made us as a primary care network quickly think about buddying up, which we wouldn't have done before, where because we're 7, we paired up and then one of us was a trio, so that if my site had to close or their site had to close, or we just didn't have any receptionist, that we could divert to another practice. So I think a PCN can be very supportive for particularly for a small practice. This is my vision. It might not happen, but I am also very concerned about losing that continuity. I know there's things I can't offer though as a small practice. So I can't offer phlebotomy, for example. We're just not, we haven't got the staff to do it. I haven't got diagnostics on my site, but I do know nearly all of my patients who have diabetes, and I actually do know most of my elderly. So online is not that hard for me because I know them already. How do we manage to preserve that continuity and give the big ticket stuff like diagnostics and everything there? I think PCNs can do it if we make up little micro teams. So I think there's a way to do it and preserve it, but I think a lot of work will need to. So in my head, I don't know how to do it yet because that will require a shared purpose for more practices. And I wonder if it's even as valuable to a larger practice who might not ever have experienced that continuity. And if you haven't experienced something, you don't, people say to me, why are you so bothered about your 5,000 patients? Why? But it's because I know Mrs. X, so I know Mrs. X, and I know that her husband died last year, and I know that this happened, and I see them as human beings, and so that's different to doing then the path link at 10 o'clock isn't just oh my god, I have to do another potassium. It's Mrs. A, oh, this is what's happening in her life, and it's a completely different connection, isn't it, when you're dealing with human beings as opposed to I've got path links to do. So I'm really with you on that. I'm hoping that PCNs are going to help retain that continuity, because apart from it feeling good and meaningful, we know that those patients, there's lots of evidence that referrals are less, prescribing is more efficient, and there was a recent article in the BMJ about how it's safer, because somebody, you know something about them. So lots of work to do there, but I think possible. That's my hope.
Well, you sound positive, and that is exactly what I want to hear from someone who sits in your position, seeing so many different practices. And I know there's lots of continuity care in larger practices as well. I'm not criticizing large. It's more personally just how to make the most of the situation we've got. So thank you.
Thanks, Julia, for that as well. We've got one last question from Nish. So Nish, are you here? Can you?
Hello. Hi, Farzana. Lovely to see you. Thank you so much for doing this, and so nice to see everyone. Sorry, I should introduce myself. I'm Nish. I'm a GP registrar at Cambridge. I've just come back from maternity leave to help lead Next Gen again. It's lovely to be back. Farzana, a question. I'm struggling with how to articulate this. It might just be because I spent the last years singing nursery rhymes, so I'm trying to find my words. But it's a question about maybe a bit of an elephant in the virtual room, which is the situation we're facing with ethnic minorities. And I wanted to ask, so I saw you on that billboard, and there you are, an Asian woman in a headscarf. I showed my mum, and I was like, look at this. This is incredible. And I'm so proud to even know you. And I bet your kids and your late mum, everyone must have been so proud. And I just wanted to ask, there's probably not that many people that look like you around the tables that you sit on, maybe even less so as you get into your national roles. How does that feel? Has it ever felt like a problem, maybe even not kind of physically, but even in your head? And what can we really do to encourage people like you to take up leadership roles?
Yes, it's a really good question, isn't it? Because being a BAME woman, I have to say, Nish, that obviously with COVID, and we know that genetically there's been a lot more deaths in the BAME community. This has really shone a light on the BAME differences. Personally, I have never faced any issues where I have felt that I haven't been able to do the jobs I want because I'm wearing a headscarf or because of my race. So I know many people have. That hasn't been a personal experience for me. But I'm very clear on shared purposes. So at the moment, in NHS Confederation, I co-chair with a white Caucasian male. My senior clinical advisor is a Caucasian male, and my primary care director is a white Caucasian female. I never see the difference between us. And I think that's because we have such a strong shared purpose, but they also give me such a respect. So if I need to pop off for 5 minutes because it's sundown and I want to do my prayers, I will say that, and then they'll be okay with that. But that's because I am stating that that's what I want to do. That's not what I did when I was in medical school. That's not what I did when I was a junior doctor. I was quite shy about that. I wouldn't do it. As I got older, probably, maybe you get a bit more, I don't know, do you get a bit more wisdom after 40? When I turned 40, it is the year Peter died, my partner died, and I thought, God, life is really short and I want to be me. So part of that was also me coming forward and saying, I want to do this, but I don't want to do this because I'm a BAME woman. I want to do this because I have the skills for the job. And I've got the skills to be here, and I can be here just as much as anybody else. So I think that's been my experience, and I haven't felt that I've been treated differently because of my BAME route, which is quite positive, because I know that's been a difference for lots of other people.
Thank you. It's really reassuring to have that message. So thank you.
Thanks, Nish. I mean, thanks everyone, because there've been some really good questions. We haven't held back at all, have we? So that's been really good. We've really got there's been tears as well in the chat as well. I think people were really moved by some of what you were saying as well.
Thank you for bearing with me. I was sharing up a bit about the team. Yeah, it was it's been my most significant pivotal moment, I think. When your team believes in you that much, how can you not give your best?
Amazing. It's been so wonderful to speak to you tonight. And yes, thanks to everyone who's joined us today as well to listen to the amazing Dr. Farzana Hussain speak. So we'll be posting this interview on our website if you would like to watch it again or share it. And Nish has posted and may repost a link to feedback forms. Please do complete it. It's like currency to us. It keeps the program going, and it's also a gift to our speakers as well. Yeah, in our experience, they really like getting it, and it's it's part of everyone's development as well, I suppose.
Really be helpful for me. And one thing I want to say, I had my model moment with Rankin, and I want it minuted that was my makeup. There was no extra professional makeup. Rankin is such a great photographer. And I thought, oh my gosh, he's made me look about 20 times prettier than I look. I'm so happy with that photo. Let it be minuted. That was my makeup and his skills and his lighting. I have had my model moment at 47.
Amazing. And there's no hiding on that screen. You look incredible. So yeah, look out for our next webinars. We have Helen Stokes Lampard coming up on the 18th of November, and also a podcast en route with Nick Harding. So thank you. Thanks everyone. Thank you, Farzana.
Thank you so much for having me. Thank you, everybody.
Oh, it's been a pleasure. Thanks.